Sorry about that. Having joined forces as NAMI activists in Northern California, Teresa and Lauren recently spent a year examining and analyzing the spectrum of housing solutions for people with SMI across their state, visiting a wide variety of programs and meeting with residents, operators, providers, and others. Their report, Housing That Heals, A Search for a Place Like Home for Families Like Ours, combines the findings from their research with hard lessons learned over the years seeking housing services for their son. My colleague, Betsy Johnson, talks a lot about NAMI mommies and how there is no force like that of a NAMI mommy on a mission. So with that, I'm so pleased again to introduce Lauren and Teresa. And
okay, can we have the slide where we're driving?
Sure.
Hello, I'm Lauren Rotaliata. My dearest youngest son was diagnosed with schizophrenia over 23 years ago, and in the ensuing years has had many diagnoses: severe depression, anxiety disorder, schizoaffective disorder, PTSD. With every new diagnosis, there has been new medications. After each involuntary hold and psychiatric hospitalization, he has attempted to stick to his treatment plan and medications, but soon the illness engulfs him again. He has tried the most intensive treatment options available in unlocked facilities, but all have failed him. We, his family, have not been successful in obtaining a conservatorship, but we were successful in getting him admitted into assisted outpatient treatment. How I wish I could say this was successful, but it was not. Not because the treatment team has not done its job, because it has. But over the past 2 years, they have never stopped trying. But what my son needs more than anything is housing that heals, where they have daily access to him, not the squalid apartment where he accesses street drugs and alcohol to ease his pain. My son has often said he does not feel worthy. He does not feel he has the right to live in a decent place. I feel the effectiveness of AOT in my county has been weakened for those who are the most resistant to treatment for 2 reasons. First, AOT needs to have access to housing that heals for those who are not adhering to their treatment. And secondly, they need a strong judicial component that holds the participants responsible for following their treatment plan. In California, we hear so much about housing first, that it is the answer, and it may be for those who need little assistance. I knew, however, for my son and for so many like him, that more was needed. I wanted to find where the best options for housing for those with a serious mental illness were in California. I wanted to influence the decision makers at the state and local level to make better use of the vast amounts of funding that were being poured forth to combat homelessness that were not helping those with a serious mental illness. I am hoping today to inspire others to join us in advancing housing that heals. On to you, Teresa.
Thank you so much. Good afternoon, everybody. It's really a privilege to join you all today. My name is Teresa Pasquini. I am the proud mom of an adult son who lives heroically with a serious mental illness. At birth, my son Danny was the most beautiful, healthy baby. He had 10 fingers and 10 toes, and we had about 18 family members at our hospital waiting for his arrival. We would have never believed that he would grow up to spend so much of his adult life shunned by society and locked away from his family because of a no-fault brain illness. The past 20 years have been a blur of suicide attempts, over 40 involuntary holds, revolving hospitalizations, and incarceration. We had resources, insurance, and my full-time ability to navigate a maze of services in one of the most integrated healthcare systems in our country, but it was still a nightmare. My son's first psychiatric hospitalization occurred in his mid-teens, and because of collaborative efforts between an amazing pediatrician and our therapist, Danny was diagnosed at 16. So early treatment began and education supports were secured. A job and high school diploma were achieved. Danny was in a peer support group, and my husband and I were in a parenting support group to learn everything we could to help our son. We thought we had managed his care. Treatment worked until the age of 18, and then the system allowed it to stop working. On his 18th birthday, Danny was hospitalized for the second time, involuntarily hospitalized for the second time. And because of HIPAA, I was literally overnight found out that I had no rights as his mom to even know where he was being held. And because my county did not have assisted outpatient treatment called Laura's Law in California, the only way to ensure his safety and treatment was to support a public LPS conservatorship. So at 19, Danny's multiple revolving hospitalizations began. He would spend months behind locked doors in faraway facilities. My son was placed in Napa County, Solano County, Sonoma County, Alameda County, Santa Clara County, Merced County, San Luis Obispo County, but rarely in Contra Costa County, his home county, where he was born and went to school and where his family lives. My husband and I would visit him every week, no matter how far away. These out-of-county placements were often the only option and prevented him from healing in his own community. When he returned to live in our home or in a community placement, the medically necessary continuity of care and supports quickly failed. So I began learning all of the systems that were designed to keep my son from healing or living close to us. I learned early on that the only control I had was over my voice and our family story. I joined every local, state, and national forum to shatter silence, shame, the status quo, and to influence system change. I served as a Contra Costa County Mental Health Commissioner for 9 years, from 2006 to 2015. And as the chair of the Adult System of Care Committee, I began advocating to bring AOT to my county as early as 2007. Then in 2009, I joined with leaders of our public hospital and became a founding member of the Behavioral Healthcare Partnership at one of the few hospital-based partnerships focused on psychiatric units. I wanted to connect our community mental health system with our hospital-based system in our county. Then in 2013, Lauren joined our Mental Health Commission, and we became partners, and along with other family members and leaders, to ensure that our county adopted Laura's Law. We finally succeeded in 2015. However, by then, my son was free-falling through the tattered safety net. But still, I was determined to help make our whole community mental health system welcoming and accessible for all and prevent the suffering my family was living. So I expanded my advocacy and began working with my community mental health, psychiatric emergency, inpatient units, homeless, substance use, detention, and law enforcement partners. It was this partnership work that took my anger wall down, and I often refer to myself now as a recovering angry mom. So it was my work with our public system that taught me that nobody comes to work to harm, and that we must all work together to guarantee that all patients receive one care everywhere. And it was this work that also taught me to never apologize for speaking up on behalf of the most vulnerable, which includes my son. I am a mom on a mission for housing that heals for families like mine, yours, and ours. So every system is perfectly designed to get the results it gets. I first heard this quote by Paul Batalden when I was learning about system redesign and quality improvement as the chair of Contra Costa County Regional Medical Center's Behavioral Healthcare Partnership. I have shared this concept with other families like mine and moms like me who, when we talk about how the California mental health system was designed for our families to shoulder the weight of caring for our loved ones without adequate support. The California system was purposely designed this way to save money, but it was a flawed design that has cost us all so much. The results of the design are scattered across our city streets, found in prisons, jails, elderly parents' rooms, and graveyards. The Housing That Heals concept is a strategy to redesign the system that will save money, improve quality of life, and produce better health outcomes for those who live with a serious brain disorder known as SMI. It is a strategy to stop the suffering of the patients, families, and providers who are serving both. It is a strategy to achieve the triple or quadruple aim and flatten the SMI harm curve. We believe that California must recognize that people who live with serious mental illnesses need more than a Housing First program. First, they need a system that cares and catches them before they fall off a cliff. A healthcare system that includes a tiered array of housing that heals as part of a full continuum of psychiatric care will prevent our loved ones from falling off the cliff and prevent our families and the providers from falling off too. So Lauren and I spent 12 months traveling across California, visiting housing programs and attending local and state meetings. We traveled with open hearts and open minds. We invited partners to join us along the way with the pure intention of developing a shared vision of hope, health, and home. We set out looking for answers to many questions. We found some. We found that there is no lack of information about the current humanitarian crisis due to an inadequate supply of psychiatric acute beds, IMD beds, or board and care beds in California for the SMI population. We found that it is no longer a secret that our county jails are the largest providers of mental health services because they are, to quote my friend Mark Gale, the beds that never say no. We found extraordinary community discussions and investigative reporting that brought awareness to the clogs and bottlenecks occurring due to the lack of a continuum of psychiatric care. Our paper refers to this phenomenon as the human logjam because it is human beings that are being impacted, not widgets on a machine or parts on an assembly line. While we did find hope sprinkled across the state in our travels, we concluded our paper by stating emphatically that hope is not a system of care, and we are determined to see California go beyond hope. If we want to stop the waste and the waiting, then we must move mountains and redesign our systems together. So our Housing That Heals paper identifies 4 drivers of death, despair, disparity, and deliberate fiscal discrimination that contribute to the human logjam. We looked back into the history of California's mental health system, and we do an overview of the missed opportunities and misdirections that have permeated our health, justice, housing, human service systems, and have influenced policymaking for decades. A search of local articles over the past years shows a trail of lost beds, lost opportunities, and lost lives. In reviewing local history, we found this old housing placement decision tree document that was publicly distributed in our county as a teaching tool, demonstrating this human logjam that our administrators, our specialty mental health administrators, had to navigate. And this was the existing system when our county first adopted assisted outpatient treatment. It reflects a system of scarcity, not abundance. It reflects the human logjam we have been trying to fix for years. So Lauren and I agreed that if we were going to unclog the human logjam in our streets, prisons, jails, and the back bedrooms of aging parents' homes, then we must focus on both the unsheltered homeless and the at-risk of homeless SMI populations who cannot live independently. We first need a right to treatment before we force anyone with a serious mental illness to fail first, suffer, and die. We believe that if there is going to be a California for all, which has become the California slogan, our governor's slogan, then California's aim must be on bridging the ideological chasm of the medical and recovery models. We know we need a both-and state of mind, not an either-or. We know that we must add both hospital-based and community-based treatment beds. California must fix the greatest source of despair, discrimination, disparity, and fund a full system of care for serious mental illness.
There are many people in the SMI population who are so ill they do not respond to treatment in a voluntary community setting. The no wrong door mantra of recent years is laudable. However, some people are not capable of answering the door when their family, friends, or treatment team is knocking. Treatment needs are more complicated than what was envisioned when the state hospitals were emptied with the assumption that community treatment would replace the need for large institutional settings. There is now the recognition that due to the severity of one's mental illness, some will experience acute episodes that require inpatient treatment. There is also the reality that not all people living with SMI can achieve recovery to the point where they can live on their own without an intensive support system. With a serious mental illness, recovery can be a direct path for some. They recognize they are ill and they stick to their treatment plan. They may have difficult periods where their illness needs reevaluation, but they have the wherewithal to seek treatment and adhere to it. For them, the recovery model works. They do well with peer support, and they may also rely on medication and psychiatrists for treatment and care. Many people like this do well in Housing First. For some with an SMI, recovery is elusive. They want to get well. They have all the intentions of following their medical treatment plan, but their illness is so intense that they stop taking their medications or following their treatment plan. Their psychosis becomes intense and they no longer deal in reality. They need a highly structured treatment plan with intense help in making them sure that they stick to it. People with SMI at this level need a campus-like setting where they may live in their own apartment or live in a more congregant arrangement. Some people with an SMI are entrenched in their psychosis. They need 24/7 medical care until they can achieve a place where they can safely live with others and enter an unlocked community. We need a way to hospitalize those who need it and community pathways to support assisted outpatient treatment for people who do not need hospital-based care. A community system and resource allocation must be flexible to move money around for the people who need it most. We need to do everything we can to marry the medical model with the recovery model in order to create a system of housing that heals.
So the criteria that we used to evaluate the housing options we visited were the Institute of Medicine's 6 specific aims that a healthcare system must fulfill to deliver quality care. Care should be safe, it should be effective, efficient, timely, patient and family centered, and equitable. These aims were first presented in the 2001 report issued by the Institute of Medicine titled Crossing the Quality Chasm, a New Health System for the 21st Century. I don't think we're there yet. So we do believe that in order to know if a housing program is healing, that it must have the ability to continuously connect to a system of care that meets the Institute of Medicine's 6 quality aims and measurable outcomes. These 6 aims must not only be recognized quality standards of care for hospital and community-based care for serious mental illness, but they should also apply to the essential health element of housing for this vulnerable population. This slide shows our adapted version of the IOM-6 based on our vision of housing that heals. We applied the criteria that we would use as moms in search of housing that heals for our sons. However, we also considered how each program might benefit anyone who needs treatment before tragedy, and we include suggested solutions for improvement. We created a roadmap for the programs that we wanted to visit, both inside our county and outside, and we intentionally set out to visit a variety of housing programs across the state. We knew that there was going to be a new wave of funding and focus on housing in 2019 because of the No Place Like Home California initiative that was passed in 2018. We knew that the initiative was going to be focused on Housing First model to address our state's homelessness crisis. We feared that the new planning might leave out those living with SMI who were at risk of homelessness, stuck in a county jail, in an unlicensed or unregulated room and board, poorly staffed board and care, or an out-of-county placement. This is the population who are often forgotten because they are currently, quote, housed, or they have a negative clinical history that prevents access to some programs. We knew that our sons would not show up in an annual homelessness point in time count, and we wanted them to be counted.
We would like to give you some highlights of our Moms on a Mission tour, from the most restrictive to the least restrictive options. We will focus on housing that is very effective to somewhat effective. We have intentionally left out the bad and the ugly. You've all seen these. Let's begin. California Psychiatrics Transitions is located in Merced County. It is a 98-bed, fully licensed mental health rehabilitation center, the equivalent of an IMD. It is not a state or county facility. Instead, it is privately owned and contracts with many counties who need a secured treatment and housing placement. The program is highly structured in a tiered level system and is an alternative to hospitalization at a state hospital. Clients must attend groups based on treatment plan goals. The highest level of clinical and staffing support is provided. Off-site recreation and social activities are offered as appropriate. The program is very client and family-centered. For 20 years, Teresa's Danny and his family endured several acute hospital stays, 2 state hospitals, many IMDs, and both small and large board and care facilities. However, none were as successful as CPT. This is a treatment center that prepares people to enter the community. Synergy is a community-based residential treatment facility with direct access to specialty mental health care outpatient clinic. It is a licensed adult residential facility. They have 3 state-of-the-art residential treatment centers in California. Each campus is dedicated to fostering a journey back to health for people with serious mental illness. It provides a team of licensed therapists, farm-to-table meals, personalized exercise plans, and equine therapy. Synergy allows individuals to move out of locked settings and into successful community living. When one enters the Synergy campus, one does not get the sense of an institution. The grounds and common areas provide a beautiful area where a person can sit and be with friends. Synergy knows that rejoining the community is an important step to wellness. What sets Synergy apart from most programs is the caliber of treatment professionals on site. There is a resident psychiatrist, a psychologist, master level clinician, and well-trained care staff. The specialty mental health clinic located next door allows psychiatric treatment to be billed to Medicaid. Residents have the ability to come from a locked facility and move from a shared room to living in an apartment on site. Synergy was designed to be a treatment facility, not a permanent residence. However, it may be home for some people for many years. In Contra Costa County, we have Crestwood Pleasant Hill that, like Synergy, is a community-based residential treatment facility and a licensed adult residential facility, but it does not have a specialty mental health clinic. This hampers its ability to provide the same level of treatment. It is known as an augmented board and care. When it opened in 2003, after an unbelievable display of NIMBYism, it was the largest unlocked treatment center in California. Today, there are about 90 people who reside at this converted convalescent hospital that has attempted an update, but is severely limited in what it can do to create a home-like feel for people. Where would its residents go while a much-needed renovation happens? So often, when people need a placement here, it is at capacity. Our desire to learn more about the John Henry Foundation was the spark that ignited our Moms on a Mission journey. Here, residents find a home in a community that is not cut off from the larger community. It provides the support needed to participate fully in life. To say we were amazed at the quality of life and the stability of those who chose John Henry was an understatement. In California, the full-service partnerships may lower the number of times an individual needs hospitalization, but what is the quality of life like for those who need to be surrounded by daily supportive services and people who they can easily interact with? Would it be possible to create programs like this in our public system? Seeing the cost effectiveness of this program, we just do not understand why there are not many more communities like this. The AOT program in our county is operated by Mental Health Systems. They have 2 group homes that can accommodate about 18 people out of the 75 people who are enrolled in the program. The housing available was shaped by the parameters our county set forth in its funding and request for proposal. The remaining people must rely on the overburdened Behavioral Health Bed Committee, you just saw the chart earlier, or the computerized coordinated entry system. Both are impacted, and the result is a human logjam. Mental Health Systems run similar programs in other counties. Here they have developed a campus-like setting covering an old resort. In 2007 in Fresno, the redevelopment transformed empty structures into a comprehensive campus of programs, including a residential care center, permanent supportive housing, and an array of outpatient and community-based services. We will definitely be taking a trip to see this, hopefully with our behavioral health administrators in tow. The last 2 housing situations we will show you are when someone graduates from AOT and can live in an unstructured situation. Oxford House is a recovery home for those who had been addicted to alcohol and or drugs who may have a co-occurring mental illness. I questioned the administrators and residents about what happens if someone relapses. Their answer was that they are immediately removed from the house. However, a written emergency departure plan in case of relapse is the first step of admittance. A resident, therefore, is never exited to the street, but into a program to obtain sobriety. They can be readmitted once clean and sober. The Oxford houses are run and supported by those who live in each house. The residents I spoke with said that the least amount of money you take from others, the more self-directed you can be. The residents emphasize the importance of being in control of their own destiny. They felt that the motto of recovery, responsibility, and replication was essential to success of each person and the Oxford House movement. Each house is a rented, ordinary, single-family residence. Those who live in a home are the same sex. There is no time limit on how long one can live at an Oxford House. There are over 2,400 Oxford houses in the United States. The last housing situation we are showing you is Kirker Court, built in 1994. NAMI family members' tireless efforts brought together Clayton Presbyterian Church and Eden Nonprofit Housing in a partnership to develop this community. The resident we were able to interview said he waited 10 years for a placement, and his family was able to get him an apartment because they had become aware of a vacancy. When we asked him about the support services that were available to him for his mental health, he spoke about his desire to be reconnected with a case manager. After living here for a few years, his connection with needed mental health services had evaporated because his family that arranged and assured that this connection was available had been lost through death. Though the county behavioral health system does not contract directly with Eden Housing, it is our hope that a partnership with one of the largest nonprofit housing developers can be reestablished. Many more sites were visited. Our Housing That Heals Heart paper describes many of these, from the shelter to pure respite housing.
After a year of traveling many miles and to multiple meetings, Lauren and I left the state capitol one day and stumbled into this statute on a nearby street. The question posed seems appropriate for our meeting today. Where are we going? Not only in California, but across the country. Our paper takes a deep dive into both research data and what we call data of the soul. We looked at where we have been, where we are now, and where we are going. And foremost in our hearts and minds was the question, what will happen when we are gone? We split our paper into two parts. The first part was focused on California. We then shined a spotlight on Contra Costa, our home county. We are encouraged by recent efforts of our county behavioral health leadership to join us on 2 site visits at both Synergy and at Everwell. We had our administrators join us, which was awesome. And they're now considering new housing program options and contracts, which is wonderful. We believe in the power of partnerships and in our community's ability to unite in humanity around injustice, inequity, and discrimination. But we worry about the endless processing, papering, and planning while people with serious mental illness are dying too young with their rights on. So not only did we travel across California, but we also traveled across the country to attend TAC's first AOT symposium in Ohio. And I was invited to attend the Healing Minds NOLA Symposium in New Orleans. And there we met moms, dads, clients, judges, providers, and friends who are amazing advocates and friends. And we are inspired by our national partners. Our Housing That Heals Heart paper asks state and local leaders and our community partners to help families like ours and communities like ours do better for this small population, this vulnerable population that has been historically forgotten. However, this conversation does not have to be California focused. It actually must be a United States of America focus. Like other families across the country, we have sat in meetings for years and watched endless system mapping events and minutes taken while our life clocks tick and our sons fall off cliff after cliff after cliff, and our families fall off too. We have endlessly watched housing plans envisioned, planned, and prioritized, but never implemented, as our sons have been either homeless, incarcerated, or placed in multiple levels of poor quality, hospital-based, and community housing. And like other aging parents, we carry the fear about what will happen when we are gone and wonder if our sons will be left with no place like home. We left our homes and our families seeking knowledge that would unlock the human logjam that currently clogs California's streets, prisons, courts, jails, acute hospital wards, ERs, and many family homes. We wanted to know, where are the healing homes in California for those living with serious mental illness? What we discovered is that there are places of healing and places of humanity sprinkled all across our state. However, we also found that housing for those with a serious mental illness is impacted at every level. This is the status quo that we refuse to accept. So we will spend the rest of our lives advocating for a full continuum of psychiatric care that includes all levels of housing that heals. That continuum must include fully funded IMDs and adult residential facilities for those who cannot survive in supported independent living and don't deserve to be housed in a jail pod or a cardboard tent. We are 2 moms on a mission to ensure that there will be a place for our sons to live in health, safety, and a forever home, and a system of care that provides continuous safety, security, stability, and serenity. We know that there are brokenhearted families like ours all across this country in search for a place like home for their loved ones. We know other moms are afraid of dying and leaving their SMI loved ones without adequate support and care. So we must continuously support grassroots family advocacy and leadership in order to build the national platform where a Housing That Heals plan of action can be built. We have seen it happen. It is possible. Thank you so much for joining us today. Thank you to Treatment Advocacy for having us, and we welcome your questions and comments.
Do you think that IMDs can be alternatives to jails? Did any residents that you interviewed mention that they have or had charges?
Well, actually my son, as those that know, since I've publicly shared my family story, my son Danny was arrested as a patient, actually, and he had been placed in a hospital because he was considered a danger to self and others, and ended up being, placed on medicine. He ended up assaulting a patient and was arrested, and picked up other charges. was determined to be incompetent to stand trial, bounced back and forth between 2 state hospitals and solitary jail cells for 4 years before I before I and his public defender actually, and my partners in Contra Costa, negotiated for him to be transferred to CPT, which I give credit for giving Danny back his life. And so he was actually transferred to CPT while he was on an incompetent to stand trial hold. They have a forensic unit there for competency restoration. And he was not ever found to be restored. And so all charges were dropped and his conservatorship was maintained. So I absolutely believe that, you know, a CPT IMD model is something that can be used to divert from incarceration.
How has the response been when you've presented this to decision makers?
John Connolly, the Deputy Secretary of Health and Human Services for the state of California, who is also the Director for Mental Health Services, he had a very extended conversation with us, and we were amazed at how aligned and how understanding he was of the problems that we were facing. So we're hoping that there is more doors opening here in California.
So yeah, we believe in grassroots advocacy, and we know it works. And we presented locally at our Contra Costa County Mental Health Commission, and they unanimously adopted our recommendations in concept. And we also recently presented to our mental health MHSA stakeholder advisory body, and we have really strong partnerships with our community stakeholders, and so we're optimistic that there will be some changes. And again, it's not, we did sort of set out focusing on our own community, our own county, but we quickly realized that this was a state vision, and now national. We believe it's something that can be a national vision. So
with our behavioral health administrators, I have to say that it's very hard to get people, it's like a barge, a huge barge, to change direction. So they keep doing the same old things as far as housing goes. But Teresa and I are not going to give up. We are so persistent. You haven't met persistence like us. We keep emailing them, talking to them whenever we can to get them to see that there are more and better options out there. And I see that we have a lot of questions on how these places are financed. And so we did show you a private pay, and that was John Henry. But I do understand that there are times when they take private insurance company payments. And I also spoke with one of the members of the board of directors, and she is wondering if they've really ever been approached by a county, because the counties are responsible for the care of those with a severe mental illness in California. If they've ever been approached by a county who was willing to make the commitment to pay the $42,000 a year that it takes, which is not all that much more than what many counties pay. And so most of the other options we showed you were in the county and were paid through the public, could be paid through the public system, depending on whether the county in California contracted with that entity. Like in Synergy that we showed you, has many patients from the different counties in California, and they contract with those counties.
So did you encounter any housing for those with dual diagnoses of intellectual developmental disabilities and SMI.
Yes, we did. But we didn't put it in our report. It was Ann Seppi in the Ann Seppi Ranch in Bakersfield. And this program, we went to see it because we wanted to do a rural farm project here in Contra Costa County. We tried everything we could to get our county to actually bring this into fruition. And 20 years earlier, NAMI families had gone down to Ann Seppi because Ann Seppi had a working ranch for those who had a severe mental illness. But over the last 2 decades, Ann Seppi had evolved into taking people who had developmental disabilities, and most people with developmental disabilities their care and treatment goes through the regional centers of California. And their pay rate out for someone who was very severe is almost $8,000 a month, can range from like $1,500 a month to $8,000 a month. In California, people with a severe mental illness and are not in the regional center, the most they get is their SSI payment, which is like a little over $1,000, maybe $1,035 goes to that. So what had happened was, over the years, Ann Seppi took more and more people with developmental disabilities who had lesser severe mental illness affecting them. And so that was that program. And Seppi, however, had contracted with another county, Ventura County in California, to take those people who nobody else would take. Those with a severe mental illness that had bombed out of every placement they had. And so they had a new rededicated unit, and it was a beautiful new unit that we were able to see. And it had opened just, I think, about a month before we got there. And that was extraordinary to see that. That unit had its own specialty mental health clinic also attached on the property. So it was a large property.
So Scott Carpenter wants to know if any of the directors of these facilities are interested in talking to people from other states. Sounds like he wants to bring some of this to Iowa.
So we can absolutely connect Scott with some amazing people, and to at least hear their vision. And I know Chris Ubbiati Everwell of Everwell would be happy to speak to you. And we didn't show slides of Everwell today, but it's a very inspiring program in the Central Valley, and Chris was also helped start Synergy, and so he'd be great to talk to. Linda Kaufman would be great to talk to, and absolutely we'd be happy to connect you with them.
Linda Kaufman is a Synergy, and I believe we even have some people on the call today from Mental Health Systems, and I know that they operate outside of California also.
Did you approach any of the places you visited in regards to creating a partnership to expand?
That we are just two moms, and we actually have spoken all the time, and we brought our mental health administrators to both this Synergy when they were expanding in Sacramento, to see the facility, to see what they were doing. And we also brought them to the Everwell site in the San Joaquin Valley, and showed them how they were able to transform properties that were pretty forsaken and turn them into places where people were receiving care and treatment. And so that is how we do it. We actually just reach out and have established really good relationships with the places that we visited, and then seeing if we can bring our county administrators to recognize that there is a better way.
Like our county to make a diagram like your decision tree, and I would like them to release anonymized data from their own bed committee and how long the waiting times and waiting lists are to get into all the boxes on a diagram like this.
That would be good.
Suggestions on how to get that?
So I think I think we actually call that out in our report, that there needs to be a more transparent process in our state about what happens in those bed committees and how those decisions are made. I mean, that's specifically something that we have stated. I know when I first got involved many years ago, I believe there were family members allowed to attend bed committees, which makes sense. And you know, or NAMI members, but not anymore. It's very non-transparent, and you know, it is what it is. You know.
Are you trying to create a nonprofit so you can receive DMH money to build these? No way.
Yeah, no.
We partner with people like Treatment Advocacy Center and our counties and other nonprofits that are out there. We will help you any way you can. But we feel that our advocacy would become almost hampered if we were to start accepting funds. We can go knock on the door and persist and ask whoever answers the door very pointed questions and not be worried about a funding source.
Do you have a strategy for combating the NIMBY issue?
Oh, well, we faced horrible NIMBYism in our county as well, and I think everybody does, from what I can see. And you know, when we were trying to cite a residential farm treatment program out in our Far East County, and it was horrible. And I think it's traumatic for our families to go through that process. But our community was amazing and just came together, and all the levels of stakeholders that are often not on the same page, we're all on the same page for this. And we did a massive advocacy effort, and did eventually get, and it took Miriam Bernard was one of our strong California advocates who wrote an amazing letter and sort of called out the fact that there was this legal thing that you could not discriminate. And so we ended up getting the use permit for the farm, which sadly didn't turn out. We weren't able to open it, but that's another story. So no, there's no magic bullet. I think after that experience, we did in our commission talk about, SAMHSA's got a toolkit for NIMBYism, and I think Contra Costa County is actually even mentioned in that toolkit from the struggle we had in Pleasant Hill and in citing the Crestwood Pleasant Hill program that we showed you today. So, we haven't formalized any kind of a plan. So.
Just last year, the California legislature did pass legislation that made it even easier for homes and for facilities to be built in neighborhoods. The problem is that many of the county, the county entities that actually review these they're not really up on the California law that says, oh no, you cannot not let these people live here. They have as much right to live here as anyone else. And so the most important thing is to be really firm, know the laws in your state, and in our state, they are coming and getting much better at it. And make sure you get to the meetings where the permits are being given, and to educate your the entity in your state, whether it's county or state, that there are laws on the books that don't allow them to do this. But that doesn't mean it doesn't happen.
Obviously, this is a national audience, and you have people from across the country wanting to follow your example, get involved. Is there a way that they can join you in this movement if they're not in California?
We have a Facebook page that we've considered this an open source learning opportunity that, we welcome partners, and, but again, we aren't going to establish, we don't have plans at this point. We're interested in helping developers site facilities in our county. I'd love to see my son come home and live in Contra Costa County before I die. That would be nice. It's been years and years and years before he's been able to live. I mean, I'm grateful that he's doing so well. But so my dream is to, expand this vision in our own county. So right now we do have a public Facebook page that people can join and follow along, and we will share updates on our presentations. We're presenting at the Putnam Clubhouse Conference next week, and it's a few other invitations that we've just received. So,
what is your Facebook page?
Housing That Heals.
So, Teresa and Lauren, gracias for your passion. So we really appreciate you taking time to speak to our community, and it's clear that it just reinforces what Betsy always tells me, that NAMI mommies are a force to be reckoned with, and we so appreciate your advocacy.